wasn't clear whether we were going to manage Neil's case, but I think we'll squeeze it in if you can be really quick, Neil. Because nothing's happened in Wiesbaden.
John, your case, rather than turning sour over here, turned sticky.
What's that?
The case, you said it turned sour, but it actually turned sticky.
Okay, Neil, go. We've got limited time.
Do you want to hear this case?
If you
sure?
can be quick, yeah, if you can be quick.
Are you sure?
Oh, go on.
Okay, then.
Well, we all need antidepressants.
All right, leave it then.
John, could I just ask you to stand up a second, please? Dr. Carroll. Just walk in front of this white thing. Could you do that? I want you to notice Dr. Carroll's footwear. You know his footwear, his cowboy boots from the West. Well,
roll your trouser legs up now, John.
So,
just stop there. Roll your trouser legs up.
No, it's all right. Yeah. But not to be outdone.
You stay in Denver for 10 years.
Well, indeed, but I was going to just say I'm making
trouser
up
legs up before you sit down. Go
Back
on.
to my slides, please.
Yeah, that's it. Yes.
So this is common wear, cowboy wear is common wear in the cath lab, and this is our senior cath lab nurse here. And this is a sort of leather-lined lead apron. So I bought a hat at the rodeo last year, and I'll show you another area of the rodeo if I've got time. Well, disclaimer, for more than a microsecond, I accept I was completely responsible for the following events. This is a children's hospital. Actually, this is mostly Dr. Carroll's hospital here, looking from the children's hospital on this big campus. It's absolutely gorgeous. So this is a 17-year-old teenager. I suppose all 17-year-olds are teenagers. And he had pulmonary atresia VSD and MAPCAS, and he had a repair by Dr. Hanley in California with a 14mm RV to PA conduit just at 4 months. Did exceptionally well. And then more recently had a second operation at the age of 8 with a 20mm homograft from the right ventricular pulmonary artery. His branch pulmonary arteries were in good shape. But he was, and again I feel stupid saying this, 17-year-old, a teenager, lethargic. Well, I've got 4 children and they were all lethargic as teenagers. Thankfully, they didn't have chest pain, and we never really got to the bottom of this lad's chest pain, even though we put him on an exercise bicycle for a while, and actually I was not massively convinced about his shortness of breath on exertion because he didn't actually exert himself. That's, you can't be shortness of breath on exertion and lethargic, but anyway. But he did have impressive clinical and echo signs of this obstruction of his conduit. And we got more than 80 on echo, and he had an MRI. He'd got normal right ventricular diastolic volume, good ejection fraction, or reasonable ejection fraction anyway, but a regurgitant fraction of his pulmonary valve of only 7%. But interestingly, aortic regurgitant fraction 3 times that of 22%, with fairly well-balanced pulmonary blood flow. So what do you think? What do you think?
Gareth?
With the numbers, the regurgitant fraction of the pulmonary valve isn't very impressive. But I mean, this is a stenosis case rather than a regurgitation case. His ejection fraction's a bit down the RV. So it seems reasonable. I know you don't have very good physiological markers, but it seems like a reasonable case to take on, doesn't it?
Okay, Elijah.
We have an aortic regurgitation fraction of 22%. So we do not have, I think, perhaps normal cardiac output. So in the setting that we do not have normal cardiac output, I don't know how we can interpret other things. I don't know.
Like what?
Because at the I like the pulmonary blood flow and the diastolic volumes.
Okay, Raphael?
Don't seem to see the problem yet.
Okay, yeah.
Do we have a chest X-ray?
Right, we'll come to that in a minute. Go ahead. Is that what you wanted as well, chest X-ray?
We want to see if there is if there is a congestion. So maybe this AI causing high LV-ADP, causing pulmonary vein congestion, pulmonary edema. causing this symptoms.
But they want a clinical examination, like a
Yeah,
chest
he
X.
wasn't in clinical pulmonary edema. He was just like your average lethargic teenager with lack of central body tone.
And what was RVEDP? Right
called?
ventricular end diastolic pressure.
We haven't got there yet.
We haven't got there yet.
Yeah.
Okay, go on, Neil. I think we'll move on.
I want to get... Harold Pribbett hasn't said anything the whole 4 days.
Where is
Harold.
he? Harold, where are you? Put the microphone on. Oh, there you are.
I'm waiting for imaging before. I can't comment on
Well,
any
we
of
got
that.
imaging. There's an MRI there.
Yeah, but I'd like to see that.
Here we are. A bit of a dyskinetic right ventricle, a little bit on the hypertrophied side. As I said, the ejection fraction, for what it's worth, came out at 20. I think I've got some other pictures. Here's got a very severe obstruction, RV function okay, but hypertrophied. I don't think I've shown you pictures of his aortic regurgitation. It's not really that unusual to have degrees of aortic regurgitation late on in the treatment of this disease, and there are several different
Neil.
reasons why you might get that. So there's a tight obstruction there on MRI.
Yep, Harold, you've got off now, so carry on, Neil.
And here's the 3D reconstruction, rather compressed, heavily calcified. So there we go, gradient approaching 90. And the pressures, Dr. Elahi, you wanted right ventricle. So it's a gradient of about 70, just low 70s. And the angiogram showed this stenosed conduit, more noticeable in the AP dimension. It's the echo, and you see a lot of calcium there. Right ventricle, well, come on, let's get a move on. That's the aortic regurgitation. So we decided to go ahead, and the intention was to implant a melody valve. One of the things I've learned from Tom Fagan, one of my colleagues in Denver, is to put a shortish, to about 25 centimeters long, maybe 30, 18 French Cook sheath in the right femoral vein fairly early on, because of all the relative toing and froing of sheaths and catheters for pre-stenting. And you can obviously get a lot of catheters down in 18 French sheath, and as it happens, you'll see that was fortuitous. But I was a bit nervous about just going straight up, so I, for emotional reasons, thought I'd go to 16 first. The intention was to put a 20mm device in this patient, but we went up with the Atlas Gold, 14 atmospheres, everything fine. We put in a 20mm Atlas and shot a simultaneous aortogram, and the coronaries looked good. So we pre-stented with a Palmaz 3010 on a 20mm Atlas Gold, following which there was ST segment elevation brought to my attention by the anaesthetist. But you can see his heart rate was pretty good, and his blood pressure really pretty good. There wasn't really any observed change. So I'd obviously occluded or compromised one of the coronaries, don't you think, Harold?
Harold, what do you think?
Yes.
Based on that?
Yeah.
Yes, he
Yes.
agrees.
So, well, what am I going to do? I'm going to sort of confirm that, right? I'll move it on, yeah?
Yeah.
So you shoot the coronaries. And the aortogram, I think I've got it on this presentation, were absolutely, definitely okay. And he was stable. So I put in a second, I couldn't quite explain it, and maybe that was my, anyway, I went ahead and I thought, well, get on with it.
But we do worry about pericardium and CNS with unexplained ST elevation.
Pericardial?
Pericardium and central nervous system.
Yeah. Okay. Well, Ted turns out is right. So there's the aortogram, and the coronary's looking good, and there we were a long way away, and I appreciate you can be a long way away and still cause problems with coronaries. The ST segments were, they stayed elevated too. And then his heart rates just started to go up a bit. Remember, we're in the high 80s, and he's up into the low hundreds, and his blood pressure came down to the mid to high 70s. So I did an angiogram, and there's an anterior leak in the proximal third of our stent. I think this shows it. See it?
Yep. Okay.
Patient, not bad actually. You see, he's got a good function. So,
very briefly, very quickly, Gareth. Very quick.
Well, if you've got a covered stent available, you'd try and put a covered stent up and seal that. Whether or not it would help or not, but I think that'd be the first thing to do if you have one available.
Okay. Well, would anybody drain the pericardium? You know, basics, Dr. Morgan. Before you start reaching for the...
Very sorry, of course, to drain the pericardium first.
As bad as Dr. Ormerod.
Yep.
So but this is part of the story actually. So there's the pericardial effusion. Ted was right, this was pericardial. I've had pericardial effusions before in the cath lab for various reasons, but I've not seen them manifest as ST segment elevation, so that was a good learning point for me. So again, back to basics. So we drained the pericardial effusion. It was clear there was also communication with the pleura. Pericardiocentesis nautotransfused. Now, heart rate, again, higher than you'd want it, but his blood pressure was well maintained. He had a base deficit of about -6. So what should we do now? There was a comment about a covered stent. This is Colorado, of course. We don't have an appropriate covered stent. Well, we have a covered stent. Who would reverse the heparin? Who would reverse the heparin?
Quick show of hands. Reversal of heparin.
Reverse the heparin.
1, 2, 3, 4, 5.
Yeah, well,
right.
I did.
About 10.
I did, and then you see what happened. And then I decided to proceed with the Melody because the Melody really was our covered stent. So I put one Melody in, and the angio showed a persisting leak, and so I thought we'd try a second Melody. Slides don't seem to be advancing. Okay, and you can see what's happened. We reversed the heparin and sees this nice tamponading thrombus, which you can see is affecting cardiac output. So I've been in trouble before by reversing heparin in a tamponade situation with a left atrial appendage, and I obviously didn't learn my lesson. So here's our drain in the pericardium, and this is our Melody, first Melody in there, still leaking. In fact, it looked even worse than the first, didn't it? Second Melody inside. And then, as I said, very little from the drain because, of course, he'd begun to thrombose that area, and he got worse and worse, as one of my children might have said. And so much so that he did require chest compressions. Thankfully, thanks to my friend and colleague Tom, we had an 18 French venous sheath in situ, which is easily big enough for a venous limb for the femferm bypass, and we converted the 5 French sort of monitoring sheath. I'm glad I had the 5 French monitoring sheath in, because some people tend to stitch in a 20-gauge leader cath, but providing the child big enough, and this was quite a big teenage boy, I like to have a sheath in there. They tend not to kink, and you're not going to get, in a big patient, problems with that. So he went off to surgery from the cath lab. Oh, and the other foolish thing that I hadn't done, and it completely passed me by, is we have 2 labs in the Children's Hospital in Denver, and one of them is the most beautiful hybrid lab you've ever seen, and the other is also an excellent lab, but it's not the hybrid lab. And of course, here I was doing this procedure, high risk, heavily calcified. I was nervous, and of course, I wasn't doing it in the hybrid lab. So, despite having a hybrid lab, I wasn't using it. So we had to take the patient off to the operating room. Now, fortunately, the suite is such that the operating rooms are really 10, 15 yards away. So that wasn't such a big issue, but I felt moderately foolish not doing a clearly high-risk case in the hybrid lab. So, and I consider myself fairly experienced in doing these sorts of things. And this patient had a long tear right down the homograft and right into the right ventricular outflow tract, total measurement of 2.5 to 3 centimeters. And thanks to, I think, all three of the surgeons, one way and another, who helped out, Dave Campbell, Max Mitchell, and Jim Jaggers, this patient actually did remarkably well and actually went home, I mean, within a week of having his surgical pulmonary valve replacement. So I think we've had calcified homografts fractured before and presented, but I'm just, as I said, disclosure, I was totally responsible. Should have been in the hybrid lab, don't ask me why, I just didn't even think. And then should we be doing this sort of high-risk case without covered stents in the lab? It's been a great paradox to me that the FDA in the States has put the ASD programs under intense scrutiny because of a serious complication. I'm not making light out of the erosive complication, but a serious erosive complication of let's say one in 600, yeah? We agree? And the FDA are tying everybody upside down and in knots. And if you look at the CCISC, if you like, the SCAI type sponsored database for aortic interventions for coarctation, the incidence, and probably Brian there could even give me the numbers properly, but the incidence of aortic disruption of one sort and another is approaching 10%. And the FDA don't seem the least bit bothered about we in America, putting non-covered stents in the aorta and not making available covered stents. So I told you about the rodeo there, and this is one of the signs at the rodeo. We're going to miss the flight if you... Yes. Sorry?
We'll miss the flight if you know.
Okay, you can buy bull semen at the rodeo, in case anybody was interested.
Okay.
And this is where I go skiing, Beaver Creek.
Thank you. Thanks very much, Neil. Okay.